Good afternoon, everyone, and welcome to the Georgia CTSA webinar on community engagement in the era of COVID-19. I'm Tabia Akintobi, professor at Morehouse School of Medicine, and I'm honored to serve as the director of the Community Engaged Research Program for the Georgia CTSA. So as others continue to come to the door and we welcome them, I wanted to share with some and remind others what the mission of the Georgia CTSA is. And that is to leverage the complementary strengths of Emory University, Morehouse School of Medicine, University of Georgia, and certainly Georgia Tech to accelerate clinical and translational education, research, and community engagement to impact health in Georgia and beyond. So we're really excited about the opportunities that this webinar brings. We hope that it enlightens you. Hopefully there's information that you hear that resonates with some of the things that you're also grappling with. And in spite of COVID-19, hopefully there's some things that you hear that help you to think about how your work can advance the art and science of more effective community engagement and research, and all of the ways that we try to collectively improve the health of Georgians, but certainly advance health equity across the nation. So we know that there are a lot of opportunities as well as challenges and lessons being learned with respect to how we navigate research, clinical care, and many other things in the COVID-19 era. All of this really has only hit us for the past 6 to 8 weeks, but certainly we wanted to take this time to learn and share experiences in community engaged research, clinical care, and practice as we adjust in uncertain times. So the purpose of this webinar is to discuss how to develop and sustain community engaged approaches that positively impact population health while navigating a public health epidemic. So one of the things that we really take pride in helping both community leaders and patient groups as well as academic institutions to do is to understand what it takes to advance what we call the art and science of community engagement. Those of you who went to school for this, whether you're a clinician or a PhD or any type of health professional, you've learned that when you get out in the field and you're engaging with real life people, that it is much more complex and messy and certainly very much worth it. And so we know that during times of crisis, there are funding opportunities that often bring people to the table all of a sudden. And then there are also the realities of the anxiety and fear that not only community and patient groups are experiencing, but we need to acknowledge this is all new to us. And so how do we adjust and realize that our research and our efforts are not only about getting to the optimal sample size, or not only being sure we complete the study by the time we said we would, but that we also build rather than fracture the relationships that are critical to not only getting us there, but advancing communities that trust us, that continue to engage in our work such that we get to outcomes, but that those outcomes are not owned by us as researchers or practitioners, but by the communities that have allowed us to co-create and to work with them. So I'm really pleased that a number of my friends have agreed to talk about their experiences in the state of Georgia. Dr. Teresa Jacobs is the clinical chair of the Georgia Association of Primary Health Care, and she also is affiliated with Oakhurst Medical Center in Conyers, Georgia. We have Mr. Darrell Sobbs, who is a community benefits coordinator with Phoebe Putney Memorial Hospital in Albany, Georgia. And whether you are in Georgia or anywhere else in the US, you likely have heard about the realities of COVID-19 in Albany. Dr. Ali Berg is assistant professor and extension nutrition and health specialist at the University of Georgia in Athens, Georgia. So she will be sharing the perspective of engaging rural patients and community residents. And then Dr. Rhonda Holliday is Associate Professor in the Department of Community Health and Preventive Medicine, and she's also the chair of our Social and Behavioral IRB, which many of us have had to navigate differently as we've had to pivot in our approaches to community engagement over the last several weeks. So our time today will be spent hearing from them, but certainly also hearing from you. So Dr. Jacobs, followed by Dr. Holliday, will share their experiences, reflections, and lessons learned. And then we're going to have a time and pause to hear from you. You can certainly use the chat box to submit your questions or comments, but we'll also open up the line for a few live questions that we want to take from you. And then we'll move on to Dr. Berg and then close out with Mr. Darrell Sobbs. The intent is to learn and hear about research, clinical realities in our state and beyond, but also about the policy implications for community engagement and related research, and how COVID-19 in some ways have democratized some things that maybe were barriers before. So let's learn, share experiences, and think about ways to collaborate as we move forward with community engagement in our state. So Dr. Jacobs, I'm gonna cue you up, and we look forward to this time today.
All right, thank you, Dr. Akintobi, for that wonderful introduction. I'm a family medicine physician. I've been working for community health centers for 20 plus years. Some of you know community health centers as FQHCs, meaning that we are federally qualified health centers. We get funds from the feds in order to see patients that are underinsured or don't have insurance, but we also see patients that have insurance. They cue up the slides here. COVID-19, this pandemic has really offered up some interesting changes for us working in primary care. And it is, has been some challenges, but we've got a lot of wonderful success stories that have occurred at our health centers. We'll go to the next slide. One of the things that many of you will see at a lot of your primary care offices, there's either a tent out or some person standing at the door taking your temperature and asking a bunch of questions. And they're also basically kind of discouraging you from coming into your primary care doctor's offices. Go to the next slide. And they're asking you to do something called telehealth. Now, I'm going to date myself. When I was a kid, I used to watch the Jetsons, and I was just thrilled to see what the future was going to look like. I believe the year was 2062, and you could see Jane and Elroy there, and little Elroy is sick, and his doctor is on that screen, and they're doing a telehealth visit. And so the future is here now, everybody. And I'm actually kind of excited about it. Many of my patients have been really excited about it as well. So we're doing telehealth medicine visits for the vast majority of our patients, because a lot of patients that we see are sick. They have comorbid conditions that would put them at an increased risk to develop COVID-19. And so we're doing telehealth. And I tell you, the positive about it is that most of my patients are extremely excited about it. They bring their family members into the visit. I get to see their gardens and where they work out at. And so, something we've been trying to get them to do is to bring all their medications to every visit. Well, all the medicines are right there at their house. And so we can check to see if they're taking their blood pressure. What's your number? Check your blood pressure right now. Let's see what your blood sugars are. And so we've had a lot of positive that has come out through COVID-19, this pandemic, since the feds are now allowing community health centers to do telehealth. Prior to COVID-19, we were not allowed to do telehealth, not for primary care. We could do it for behavioral health, but we couldn't do it for primary care. So now we are doing it for primary care. Some challenges that we've had is there are some patients that are in areas without broadband, or they don't have a smartphone. And so what's nice and interesting about this, many of those patients qualify for what they call is chronic care management, meaning that if they just have a telephone, that we can speak to them by way of telephone and still give them give them everything that they need. And so we've been fortunate in that area to allow us to do that. There are also a lot of grant and projects that have started in the midst of COVID-19. And guess what, guys? Some of these projects are giving out free blood pressure monitors. They're giving out blood sugar monitors. They're giving out thermometers. They're giving out pulse ox so that patients can check their O2 or oxygen saturations. So even though we're in the midst of a pandemic, there are some great things that are coming out of this that, from my understanding, on the other side of this pandemic, whenever that is, we are going to still be able to do some of the things that we're yet doing now, which I think is absolutely wonderful. Now, most doctors' offices are doing limited amounts of in-house visits, so it's not like they've stopped all visits at primary care, but you now have to call, and then the visits are now spaced out. And children has been the biggest hit in all of this, and that parents have been pretty reluctant to bring their kids in to get those immunizations. So that's a challenge. So we're still getting the word out that those children still need their vaccines. And so you really, really should be bringing those kids in. But overall, our what's been happening with COVID-19 when it comes to primary care has actually been fairly positive. And as far as the mechanics of what the future in medicine is going to look like. So we are excited about it. And somebody said, has telehealth replaced house calls? In a sense, actually it has, because if you have a patient that has the ability to check their blood pressure, to check their blood sugars, and to even, like for those with congestive heart failure, they can actually weigh themselves if you got a scale there. And so what the future is looking like is that there's going to be a way where those values are going to actually be downloaded into their charts in our clinics, which is going to be great, guys, because it means that we're connected with our patients and we'll be able to see if there is an issue with their blood pressure or with their blood sugars. And so I'm really excited if you haven't noticed that. I'm extremely excited, but we are accommodating. I just want to make sure that we are accommodating those patients that are still a little reluctant about telehealth. And so I am going to close there to let you know that things of medicine is still rolling on, and we still are taking care of those primary care patients, whether you have insurance or not. And so we look forward to continue to do what we do in our communities. And I'll end there. Thank you.
Thank you so much, Dr. Jacobs. You all please tee up your questions in the chat box, because after our next presenter, we'll certainly respond to some of those questions, both for Drs. Jacobs and Dr. Holliday, and then we'll open it up for some live questions as well. Dr. Jacobs, I heard something that sounded like the democratization of telehealth, which was not so before. And so when we think about the realities of people being in counties where there is no hospital, right, or primary care physician, the realities of serving those who are, geographically dispersed, those opportunities seem like ones that are as a result of COVID-19, but that present great opportunities. So please put your questions in. There are actually a couple that have come in. Put your chat box questions in, and certainly we look forward to responding to them shortly. So next is Dr. Rhonda Holliday. Again, she's with Morehouse School of Medicine, and she also chairs our Social and Behavioral IRB. Dr. Holliday.
Hello, good afternoon. Today I'm going to talk from the perspective of a researcher and from the perspective of the chair of our IRB. My research has typically focused on HIV prevention, and my projects for the last few years have involved high school students and getting ready to start a project that involves college students in their surrounding communities. So as you can imagine, the project with high school students, we were in the middle of wrapping up that project right when COVID hit, and wrapping up some data collection for a small pilot project that we were doing. And what this essentially meant was that we had to stop all data collection efforts because the schools literally shut down, and there was no access to those students. And the focus of the schools completely shifted, as it should have. So now they're focused on distance learning, providing technology and access to that technology to their students, and even things such as providing access to food and just basic necessities. And the same thing is true for our college partners as well. They too had to switch to distance learning and focus on some of those things to continue instruction through the end of their school year, but also some of the basic needs of their students. So what this has really meant is that we have had to be very, very flexible. We've had to rethink our approaches on how to engage our community and how to engage our participants. We've also had to really start thinking about forward thinking in terms of how we're going to continue to implement various phases of our projects and developing contingency plans. And I like to say that we have to consider not only our contingency plans, but contingency plans for our contingency plans. And just being very sensitive to the realities of our community. So what is challenging for them? What are they primarily concerned about? And one of the things that we've had to really be aware of and make sure of is that we communicate these realities to our project officer as well, to let them know that in the midst of in the midst of everything that is occurring, that our research is not going to go as planned. And I think that they are aware of that and are very understanding of that. Some of the other challenges that we face. So as part of our data collection for one project, we are scheduled to do key informant interviews, focus groups. That was our method to gain some preliminary information. And of course, you all know that key informant interviews and focus groups are typically in person, face-to-face, sort of a high-touch data collection type of activity. Well, of course, we can't do that now. And so we have had to switch our data collection to a virtual platform. And we are using Zoom because that is what our institution provides. And Zoom allows for the connection via internet and phone if an internet connection is not available. So we're aware that this may impact some of our participants or potential participants for this project, in that if they don't have a stable internet connection or don't have access to a phone, they may not be able to participate. It also meant that we had to develop new protocols for conducting our research activities. So what we had written that we were going to do, which was typical for procedures for a focus group and for key informant interviews, we now had to go back and talk about how we were going to do that on a virtual platform. And so this will bring me to the IRB perspective next. So when thinking about using virtual platforms to engage the community in research, some of the things from an IRB perspective, and I think also from a researcher perspective, that we need to keep in mind is, what does this mean for the privacy and confidentiality of our participants? How are they going to have access to this platform, particularly for those who are located in communities that may not have access to internet, or they may have internet, but the connection is not great? How do we reassure them that their data is safe and that they're safe from outside intrusion? I'm sure that many of you have heard about the Zoom bombs that can occur, but how can we prevent that from happening? And then also, So how will the dynamic between the research staff and the participants be affected in this virtual environment? How do you read body cues and language and things like that? Also thinking, how do we look at now the risk-benefit ratio? Are there new risks from participating in research that we have to think about now? How will these risks be mitigated? And is the research going to place an unnecessary burden on the community? Is this just one more thing that they have to do in the midst of everything else that is going on in their lives as a result of COVID-19? Will there be any stigma associated if you're doing a project that is focused on COVID-19? Is there any stigma associated with that? And how do you mitigate that? And how do you make sure that your participants are protected? And then start to think about, once those restrictions are relaxed, how do you continue to mitigate the risk for the participants? So Georgia is opening up, but there are still risks that are there for individuals. So just a few recommendations is that community engagement is really all about listening and reacting to what the community tells you they need. So engage in more listening. Of course, be flexible and empathetic. When you reach out to your community or your participants, sometimes you will need to allow that space to start at the beginning of the communication to acknowledge the reality of where we are with COVID-19 and how that may be affecting them. Community engagement has always been and always will be about listening to the needs of the community. COVID has not changed that. And so on that, I will end my presentation.
Thank you so much, Dr. Holliday and Dr. Jacobs, both from the clinical as well as the social behavioral side of research. You shared some important nuggets that, acknowledge the things that we're all navigating since COVID-19, but there are some things that certainly remain in terms of trust, relationships, and addressing the research reticence that we know exists among many communities because they're in rural spaces, because of their identity, whether it's related to race, ethnicity, socioeconomic status, among many others. So there are a few things, comments that have come in the chat, and Dr. Jacobs, I don't know if there's any comments that you might want to share in response to some of those. I know you have to leave the call in a bit. But are there any comments or responses that you want to share with the group or in response to some of the questions that came in before the webinar?
Yeah, there was a question about rural communities and that the limited availability of smartphones and stable internet. And the person is asking, what kinds of things or what are they doing to expand telehealth out there in those communities? Well, some community health centers actually have mobile units that they are actually starting to go down into rural Georgia, believe it or not, and offering care on the mobile units as well as offering internet from their mobile unit, which I think is just a brilliant idea. And so that patients can have access to telehealth care by utilizing those mobile units or medical mobile units. So they're in pilot programs right now trying to see if it does work. And so the preliminary data that's coming out now is suggesting that it's a great, wonderful idea. And I understand that even there are some communities that are sending out the school buses that have internet capability as well. So rural communities are on our radar, always have been, and trying to get them help is one of the priorities of most of the primary care providers at community health centers. And so those are some of the ideas. We're also lobbying for broadband to be expanded in those counties that still do not have stable broadband. So we've spoken to the women legislators last year down in Savannah. They heard us and they are taking up the cause and pushing for broadband, especially since CMS has said that it's okay for all of us to do telehealth now. So they understand that broadband has to be in all of our counties and easily accessible and stable for our folks that are down in those communities where it is not. So it's on the radar, and I'm looking forward to seeing what some of the studies that some of the health centers are doing, what the results are. And we should know those fairly shortly.
Mm-hmm. So there are a couple of questions that came to us before, and I just wanted to pose them to Dr. Holliday and Dr. Jacobs before we pivot. Some of you all are, we're having a lot of great chat discussions, which I think are relevant to this. And after I share these questions and get these responses, we'll open up for folks who want to maybe share a real-time question or comment or reflection on their own experiences right now. So the first question is, many healthcare providers and researchers are relying on telemedicine and online meetings while we shelter in place, which both of you have discussed. But as we know, many Americans do not have access to the internet at home or cars to participate in drive-through services. And I think, Dr. Jacobs, you spoke a bit about some of the mobile work that's happening. What are some of the other innovative ways that you see being used to reach those without internet access or transportation? And there may be those on the phone that may have some perspective on the phone, on Zoom, that may have some perspectives too that you can put in the chat. But we know this is something that was real before and certainly really just kind of magnified during that time. So Dr. Jacobs or Dr. Holliday, if you have any other reflections given that question, we'd love to hear them before we pivot.
And I'll add that some of the clinics are doing drive-up clinics. So not only are they doing COVID-19 testing, but they're also doing primary care. And so you drive up and get your care. Who would have thought that there's a drive-up clinic so that you can get your care and you don't even have to get out your car. So that's one thing that a few of the clinics are trying, and there was a clinic, they did that just last week, and they said it was extremely successful. They saw well over 100 folks because they were there to get the free COVID-19 testing, but many of them were able to get refills on their diabetes and their blood pressure medications all at the same time. So that's another innovative way if they have transportation. There were some patients that did walk-ups, so they were able to practice social distancing with those folks and still take care of them as well. And I'll let Dr. Holliday take it from there.
Yeah, so we all know that technology is great until it's not great. And not having internet access is a real challenge for some individuals and will pose a challenge for research. And we may want to consider that, you know, there are some people who still have landline phones. And so maybe doing something that's a little bit old school may actually be innovative right now, reaching out over phone lines, particularly if you have a survey that you were trying to have completed, using mail to do those sorts of things, to gather information. We may have to rely on some of our older technologies in order to engage the community. I think what's really important, though, is that trying to maintain contact with them. So it may be that we may have to institute more phone calls, and just trying to make sure that we keep them engaged in the process and figuring out and working with them to figure out, you know, what is the best way that we can keep you engaged in the research process. And, you know, it may be that part of the research has to be put on pause and figuring out how to what you can do in order to advance the research, and then picking back up again.
Thank you all so much. So 81 people on the line, and we know even if we were all together, we couldn't all speak at once. Thank you. I see a hand that is up. So we're gonna allow those who may want to share a comment or question in real time to do so. And I'm looking at Melissa had her hand up, so I'll let her go. Go ahead, Melissa.
I just want to make sure that all these questions in the chat are getting answered, and some of them, most of them have been answered, but one in particular that hasn't been addressed was asked. I know that the governor has made rural broadband access as one of his key campaign initiatives. Does COVID make this more likely to happen?
My response was it remains to be seen. All of this is new territory for all of us, and so certainly that is one that we need to be watching closely. There's a lot of things that are coming out with the intent to be positive, and we certainly hope that they are. But a lot of this, I think, really requires, and I look forward to collaborating with the team science group. Once we get a bit farther out from the realities of COVID-19, we certainly should have a follow-up, whether it's with team science or the community engagement program, to see really how the politics and the decisions related to a lot of what's now available, how it actually impacts community engagement and access. So thanks for that question, and we certainly will need to continue to look at that. So does anyone have a comment or a question that they would like to share live? So we'll leave a minute or two for that. So just make sure you unmute your phone and share your comment, and it can be from anyone, whether it's Georgia CTSA and certainly those who are joining us from across the state or beyond. So Miss Nicole Baker raised her hand. Please, Nicole, go ahead and unmute yourself. The floor is yours.
Okay. Hi, everyone. My name is Nicole Baker. I'm actually over at the Emory Hope Clinic. Typically, you work in HIV prevention and vaccine research, but our clinic has completely converted over to all COVID research. So I think one of our struggles so far has been, we used to be a really great source for the community for sexual health information, really just, and having to kind of rebrand in a way and make people kind of understand that all of those studies are on pause, and how we've kind of even shifted populations. We used to work with a lot of MSM, especially minority groups, those at high risk, and with all these COVID studies, we're moving more so into really kind of just broad population overall. So I think that's been difficult, but one thing that I did have a question about, we know that COVID is disproportionately affecting minority communities, and how we can kind of make sure that those populations are included in a very meaningful way and getting their input, but having these barriers such as access and like internet and things like that we already know plague these populations already. So just kind of trying to get a feel for what people are doing on that.
Dr. Holliday, do you want to take that?
Yeah, so again, I think it's a difficult issue, for one, because there is no control that we as researchers have in terms of access to internet. There may be some ways that perhaps you can reach out to local providers of internet to see if you can form some type of partnerships with them. That could be one way that you could try to address that lack of access. And I would think that, or hope that you all are working with maybe partnering with some organizations that have access to those communities. And I would just really just talk to them about ways to reach the population, and either on a digital platform, like what would be the best in terms of, maybe there are some social media platforms that you can reach out to people and have them contact you. But I think it's going to take some collaboration with maybe some partners that we have not typically collaborated with before. So maybe someone like a Comcast or to talk about providing internet access or hotspots and things like that, and just kind of stepping out of our normal box in terms of who we collaborate with and how we collaborate with them.
Thank you.
Anyone else have a hand that you want to put up so that we can have you share your comment or question with us now? So great chat and discussion, and I think one thing that really is that Nicole just raised, which is so important, an opportunity during this time, is that all of the chronic conditions, health disparity populations, and issues that existed before COVID-19 are really just being magnified now that we're in the midst of an epidemic. I think people who had not heard the term health disparities before are hearing it for the first time and are aware now of a lot of the inequities that existed before. And so the great opportunity I think that we have is to really collaborate, listen, and really help to create meaningful conversations surrounding what this means for communities, but help them to unpack why their voice matters, both in research and in broader population health. A lot of them now have questions that they didn't have before, are making connections to the reasons why they engage with us because they see it now as being a part of the public conversation and dialogue. So this is really a great opportunity now that ears are perked and really the world is listening. So I'm really pleased to have Dr. Berg, Ali Berg, to share next. She is assistant professor at University of Georgia. She's also a part of our Georgia CTSA community engagement function. All those that you've heard before are either at one of our partner institutions or a part of our leadership. So we are statewide, and I look forward to her sharing what she's doing in Athens and beyond. Ali?
Thank you, Tabia. And if you can give me a head nod, if you can see my screen.
Yep.
Great, thank you. So as Dr. Akintobi said, I'm Ali Berg. I'm with the University of Georgia Cooperative Extension. And I'm going to give you a little background on what Extension is, just for those of you who are probably thinking, what is that? So you kind of have an understanding of how we work. And I'll try to move quickly so Mr. Saabs has a chance to talk too. So the Cooperative Extension Service has been around for a long time. It was established in 1914 with the Smith-Lieber Act. And the whole goal was to say that the research and the education of the university doesn't only belong to the researchers and the students, but it really belongs back with the state as well. And so the Cooperative Extension Service was established to be able to do just that. And we exist through land-grant universities in 50 states, 5 territories, and over 3,000 counties so that we can extend that education and resources of the university to the community. So what that looks like, we certainly do research, but we do a lot of other things too. We do a lot of educational programs. We offer one-on-one consultation with folks. We provide a lot of written extension materials. So in the wake of the pandemic, we've been preparing a lot of materials for people to understand food service regulations, safety and sanitation, how to clean your home, considering mental health for youth as you try to work from home and help them navigate the pandemic. And we also do a lot of work in community development, which is quite varied, but one of the things we've been doing more frequently lately is working on building coalitions, specifically health coalitions, to address community needs. And the most important thing about what we do is our people. We have community-based educators. We call them extension agents, and they are the agents of the university to have that extensive reach throughout the state. And they are based in those counties. So they are existing before, during, and after any research that we do, and they are the ones that are delivering the educational programs. And they're supported by state-level specialists like myself who bring in the grant funds and help conduct the research, provide that content expertise, and really train our people so that they're competent educators. So one of the studies that we have going on right now kind of hybridizes that educational programming and research together. It's creating a healthier Georgia through diabetes prevention. And we are doing it in 13 counties right now, and it's about a year study. And we're delivering that Prevent T2, or the diabetes prevention program as you know it, with Fidelity, layering on a little bit of social media enhancement and looking at typical health outcomes, but also some novel health outcomes like physical function, and also really exploring extension as an implementation context. And so that's the study where we've really been faced with the changes with COVID-19 right now for me. So as I mentioned, it's a year-long study. We had planned to do weekly in-person education and then move to monthly and do our data collection as typical, baseline, midpoint, and post. We had our stuff set up to do some online and some in person, but as soon as COVID hit, that all changed. So like many other people, we are now moved on to a virtual platform. We're using Zoom to offer our programming. And then we are considering how to manage our data collection, especially as we come up on this midpoint. Certain things just can't happen now because we can't bring people together. But other things, we're looking for ways to do that virtually. So I think I have a lot of the challenges and opportunities that others have spoken of already, so I won't belabor the point of rural broadband issues, but I will say that, some of our folks who said they did not have any way to access the internet prior to all of this starting, suddenly they're finding a way to access the internet, or a smartphone is appearing that wasn't there before, or they're just making that a priority to get that. But also, making sure that those who don't have the capability to do online meetings can use the telephone function for things like Zoom. And when we have half the group that has telephone only, trying to consider equity and then maybe having everybody do telephone only, so it's not just one person who's kind of out of the group there. With our older adults and some of our lower literacy audiences, we had some concern with ability to get online, but this has really been an opportunity to help people with skill building. I think I saw somebody in the chat box, maybe Dr. Pearson or somebody else, that said, these people have been excited that they have an opportunity now for social connection during the pandemic. And I think that that's been really important and maybe a way for, especially our older adults in the future, to continue to have that connection when they feel isolated. Similarly, we were worried that some people might not have an interest in moving online, but because of the current situation, that's been an opportunity to have connection with others. And for a diabetes prevention program that can sometimes maybe get a little boring after a while of participating in the program, people are now seeing this as their weekly opportunity to connect with others. And then Dr. Holliday already talked a lot about focus groups, so I won't say too much about that. I know we're gonna try to do our focus groups online. That has new challenges, and I'm curious to see how it affects participation. Like, for example, if maybe somebody couldn't participate before because they couldn't leave their kids at home to come participate in a focus group, but now maybe they can do it because their kid can sit in the next room or next to them while they do it. So I think there's opportunities that come with the challenges. And some of our lessons being learned, because we are still very much learning, as Tabia has so well said, I think established trust is key. As I mentioned, our community leaders, our extension agents, they're there already doing the work before any of these studies and issues come through. And so people trust them to help them get on their computer, to help them learn how to use their smartphone, to increase the font size and things like that. I think it's important to be sensitive to the immediate needs of your participants, that, research is not necessarily at the top of everyone's list, and especially right now when people are sick and when their time and their resources are being distributed differently. So I think it's important to be very respectful of that. So, as I mentioned, some people are coming up with the resources to be able to get broadband, being very respectful of those who do not have those resources and not trying to push them too hard on that. And making sure that we're helping in more ways than just research. So knowing that when we spend time to help people get on their computer for Zoom or use their phone, they might need a couple of extra tips on how to use their phone then to make that call with their grandkids, and which we're happy to do that. And I think there's, as other people said, lots of funding out there. It's important not just to capitalize on that, but to be sensitive on how that's going to impact your community and your relationships. And think about how you can use that funding to really transform the community and lift them up, rather than just get a study done for the sake of getting the grant funds and the knowledge that we need at the universities. So I think our pathway forward is certainly uphill and a little bit crooked, and we don't really know where it's going to lead. But it's certainly, for us in Extension, has opened us up to more online program delivery, online data collection. And I think it'll be very important for us to ask our community what those next steps should be as we move through this. And so, trying to make sure that we're with them now. We were with them before, we're with them now, we're going to be with them in the future. And what do they want to see happen now because of this? Because I think their minds are open to what our new reality looks like. And so with that, I will stop sharing my screen and I can turn it over to Daryl or Tabia.
Yes, thank you so much, Ali. We must proceed with relationships and trust in mind. And, when those things happen first, the other stuff is easier and can all be successful. So intentionally, we're closing this with Mr. Daryl Saabs, and he certainly can use all of the time, and even if he doesn't, or as he considers how much time he wants to use, we are looking at the other questions that have come in, and I'm hoping that Lauren or Katie will not cut us off right at 2 if we still are going on, because there are really some great questions that have come in before that we want to pose to the whole panel. But Daryl Saabs is on the front line. Not only in the communities of Albany, Georgia, but certainly with state legislators and policymakers. His perspectives include those of clinical practice, community, policy, and research. And so the cross-cutting theme here is community and all that he does. And so we're really honored to have him as a part of our community steering board and to have him share with us what the reality is in Albany, but what he sees as some of the path forward, both as one who collaborates with and leads in spaces in Albany and beyond. So Daryl, the floor is yours. Make sure you unmute.
Am I muted?
Not anymore.
Okay, good. Thanks for the opportunity to have the conversation. I purposely wanted to be last because I wanted to have the opportunity to hear and to listen and to say to all of you how proud I am of all of you. I mean, you know, all of my CTSA friends across the network, you guys are the construction workers of truth, in my opinion. I mean, I come into the work as a community organizer, sort of a social justice advocate kind of experience. And so my interest has been looking for the burdens and looking for the challenges in families and communities, and have them move from being fragile to being communities or families of strength. So in order to do that, you had to have the tools, you had to be able to work with families, you had to be equipped to do it. And CBPR to me was the theory or the formula that I found working with you guys that really seemed to work, because it gave us the research and came right up with the evidence. And so I am so pleased at how smart and how effective science makes all of us. So, and I say that all the time. So we knew that just our work in prevention, that the comorbidity was really an issue, and how, you know, trying to bring some control to chronic diseases. We knew that obesity complicated issues, that high blood pressure complicated the issues, that poverty and zip codes really mattered. And so that was something that we really knew even prior to this. But just as we are familiar with the politics and the policies that affect these conditions, the dilemma starts with the theory and the responsibility to the question, is healthcare a right or is healthcare a privilege? So, you know, in some conversations, that debate has a huge division in ideology and acts out in real partisan behavior. There are many who feel that a system that people can afford should be a system that could give them the best that their money could buy, let's say. And other people feel like, you know, dying is important, and that we do not want to see somebody who can't afford to live have to die. So it's almost as simple as that. But that debate and that dilemma we see quite often in the state legislature, and most state legislators have tried to find a compromise to give you a bit of both. You know, our state and our legislators are having a tough time trying to find that balance, because although there's a life and death decision that are going on right now surrounding the question. There's also a lot of cash. There's a lot of profit. And there's a lot of commercial vendors profiting from the same issue. Pharmaceutical companies, insurance companies, medical costs, are driving that dilemma. And so how we work with this and how we deal with this in the legislature is a very difficult issue. Georgia chose not to expand Medicaid. Georgia also decided not to give indigent funding or a lesser amount of indigent funding to our hospitals, and mostly, especially those safety net hospitals. And so neglecting rural hospitals and healthcare has really been a problem for us in the state. Like in our area, we have 9 counties that have no doctors. We have 60 counties that have no pediatrician. We have 70 hospitals that have closed. And so, I say it's a pretty big issue, but there's a lot of conversation happening in engagement, because engagement to me is so important, because you're sharing and you're caring and you're giving strategy, you're giving opportunities for exchange and building trust. And the CTA believes, that's what I love about you guys, because you believe as academics and as educators that it's important. And you might not be a community organizer, you might not be a lobbyist, but you do produce citizen scientists like myself. I mean, if it weren't for you and me meeting you, I wouldn't have the knowledge of what I'm looking at in the vein that I do. So we're learning in real time that science and evidence is key to human life. And I love that. And you must love that too. We're known all the time, but now publicly, it's being stated that only science can get us out of this. And I think that that's a point that really resonates with families. It gives us a very unique opportunity that we can do exactly, I think, what we want to do in families and communities. Helping families commit and think through and work through priorities, or improve health status, or understand health equity, and training local leaders. There's an opportunity, a vast opportunity for that. But we got to be patient. Dr. Akintobi talked to me the other day about a focus group that we did together. And she said that one of the biggest difficulties was that it took about an hour to get everybody hooked up logistically to the technology of a viral focus group. It's that kind of patience that I think we're going to have to employ as we move forward. There's a gold mine of talent and resource out there just desiring your input and your guidance, and will trust in you. When death becomes imminent in the population, people are really searching for truth. They're searching for that safe spot of knowledge and information, and all of that sort of lives with you with the work that we're doing. And so I'm very encouraged that we're living in breaking news time, of course, and some of the core projects, as I think back, that you've done before and you've put on the shelf will probably give you some of your best results right now. Some of your research questions dealing with better understanding of beliefs and behavior in people, or creating actions or opportunities to employ best practices will be exciting again to people. Many grants, I think, will work in faith-based organizations, because people in congregated places, once we ease restrictions, will want to do something and do it better. So building strength and sustainability, like the technical assistance that you guys have and know so well, that's needed in communities, like training folks on how to be community health workers, or training them on how to be sustainable with fundraising and grant writing and things like that. Things that I know that you're the experts in. And I think with the goal being that we want to leave them with an element of wisdom, and actually we want to promote more citizen scientists. And I think nobody can do that better than this group of people that we have in this audience. So I'm gonna stop right there and let you guys ask any questions.
Thank you so much, Mr. Saabs. This is really great in terms of us seeing the big picture. You said something that we probably never have had to face so immediately before, and that is when death is imminent. And of course, that doesn't sound great, but the truth is people are listening more so than before, because in many cases that has been the reality. And so for those who trust us, this is an opportunity to tighten that relationship. But for those that maybe relationships are new, it is an opportunity to do things the right way because communities and patients are listening. So I have a couple of questions again that have come through, but others can certainly continue to use the chat. For anyone on the panel, and of course anyone who's on the phone, you can certainly type in your best thoughts about this too. What are some suggestions for keeping potential participants in research or in your care engaged while studies are on hold? What are some suggestions for keeping patients or communities engaged? Because we know that for those of us who are researchers, attrition is real. So people already have a tendency to drift because research is not the only thing on their hierarchies of wants or needs. So what do you all think are some of the ways that should happen, or that you've been doing that you think are important and people have been receptive to?
Well, I think some of the immediate needs, as Darryl talking, are being met, like in our area where it was sort of an initial breakout here. Some of the first things that happened was the whole infrastructure, because there wasn't a best practice for epidemics, right? So we had to create what the model would be and how it would work as we were building it. And so the first responders working with other first responders, working with hospital emergency rooms and moving doctors around. And then the immediate response once death got so imminent was, what about my food? And so food distributions had to be put in place. And emergency needs of people like pharmaceutical needs had to be put in place. And it was not difficult. Thank goodness we have social media, because if we didn't have social media and that ability to communicate during this time, and we're talking about taking advantage of that now. Of course, we need the broadband with that technology, but most of what we're building and delivering have to do with real immediate life and death needs right now. Folks in this community, everybody knew somebody who died. And so we're just going through the grief of that and trying to bring our lives back together from that. But I know the undergird of that question is, how do I get better? How do I eat better? How do I lose the weight that, because we saw that the comorbidity issue was an issue that exasperated the death here. And so that's why I'm saying what we've been doing in the past, don't feel dismayed about that, because that will come back around.
Tavia, you're on mute.
Thank you, Ali. I'm going to give the chair of our steering board, Nisi Johnson, a chance to say something, and then we'll proceed with continuing the discussion. Great dialogue. Nisi? Nisi, are you still there?
I am. Thank you so much, Tavia. I just wanted to say hello to everyone. Hi, you can see me. So sorry I wasn't there at the start of the webinar, but I welcome everyone. Feels like you have been having a wonderful dialogue and sharing great.
You're breaking up, Nisi.
And nonprofit organizations alike. So I strongly encourage you to continue the work that you're doing. Send over those questions in our dialogue in our forum coming up in April of 2021.
Thank you so much, Nisi.
Absolutely. Thank you, everyone. I'll stay on as long as I can.
Great. So I did see a hand up. I think it was Miss Adrienne Proler. She is a community health worker with our Georgia CTSA, but also is the Georgia representative for the National Association of Community Health Workers. Go ahead, Adrienne.
So, Daryl, I'd love for you to address, I understand that a lot of the community spread originally in Albany had to do with people attending funerals. How can you address what's being done to address mental health issues when people can't gather to grieve in traditional ways? I lost my father in Hurricane Katrina, and we couldn't have his funeral for months. Mm-hmm. So can you address how you're handling that in Albany?
And you're on mute, Daryl.
How about now?
You good? And you just click back on. You just went mute again. There you go. Press again. Press one more time. You're on mute.
Where am I now?
You're perfect.
Okay. So, okay, being called the epicenter wasn't a good description to be called. You know, we just didn't know. There was a person who came from Atlanta who came to attend a funeral, and when the person got here, they were very, very sick. COVID had not been identified at that point, and we saw the person. The person went to the funeral and went back to Atlanta and further exposed. We thought that he was just going back to see his doctor. He was very sick and he wanted to go back to his doctor. Once he got to his doctor, he was already lit up with COVID and spread it there and here. And once it happened here at a funeral, you know how people hug and embrace and share grief at a funeral. It happened at another funeral. During that same week, some of the same people went to another funeral. So it spread in such a large population of people, and no one knew what it was until the cases started to come into the hospital. And when that began to happen, of course, it changed the whole flow of our priorities and what we were doing. We set up a command center, much like walking into NASA. And that was to our advantage. We had a couple of people on staff that were former FEMA workers, so they knew how to put together a command center so that all the executive leaders were together for the whole health system, and we were able to in real time judge what to do with cases that were coming in, how to prioritize. The ICUs got crowded right away, and we had to try to find other partnering hospitals to help us out to do that. Now, at the same time, again, there's no best practice for COVID. There's no model for it. So we began to establish CDC guidelines, and lo and behold, they begin to conflict with state guidelines or public health guidelines, and it created a problem. So the messaging became important. We didn't want to appear to scare anybody or to seem negative to the state of Georgia of what we were doing. Since the person came from Albany, there were some rumors of us spreading to Atlanta. So messaging was important. So trying to balance all of that and manage all of that in real time while we were still seeing people come in, and funeral homes then had to change their protocol, and some of the guidelines had not reached them. Some were doing big funerals, some were doing small funerals. So we're almost at, you know, closing down, as complicated as it sounds, was easy. It's opening up that's difficult, because people have so many diverse opinions and ideologies about where we should go. How it becomes a dilemma between health and wealth, I don't know. But I'm talking to a group of people who are scientists who mainly stick with the facts. And I think you understand the responsibility that humans should have to one another at a time like this. But we just got to wait it out. And then in the meantime, we know exactly what protocols to follow. It's been very hard for people to experience death and they couldn't be by the bedside, or when somebody has to be. And now I also have a funeral home. So I'm in double jeopardy of this. I have a funeral home, and we've seen in Sumter County, there's been about 2,000 cases of positives in our area and out of that, about 200 deaths across the system. So we're learning as we're going, but the biggest thing that I'm seeing is people are saying with much hunger, what can I do to prevent this and stop this from happening the next times? And we know that the next time is soon without the science of a vaccine.
Thank you so much, Daryl. And so we know that physical distancing, even when there is no tragedy, it can create issues of increased importance when we think about mental and behavioral health. So Adrian, your question is an important one, and certainly we'll be sharing an event that we'll be hosting next week addressing behavioral and mental health with this group for you to share with the communities you serve and maybe even you, because this is new territory for all of us. Cheryl Simpson had her hand up. I don't know if she's still on, but if Cheryl, you can unmute yourself, we'd love to hear your comment or your question.
Hi, good afternoon. Again, my name is Cheryl. I am the community engagement lead at Morehouse School of Medicine, involved with the All of Us research program. And so I'm so happy to be a part of this forum. Just too quickly, because I know the time is going, brief statements. One for Ms. Adrian. Just recently, I had a relative who passed of corona, complications due to corona, and also a church member. Two very different situations. The relative was out of state, and of course we could not travel. They held her body for some time, and finally we were able to participate via Zoom. They actually Zoomed the funeral and the memorial service, and that gave us I guess as much, satisfaction, if you will, or comfort that we could under those circumstances. So I think more and more people are turning to that. It was very tastefully done. It was just a few family members that could be there. By law, that's all that they were allowed. They still, had on their attire or whatever. The casket was dressed, and we could hear poems and words and sayings, and it was wonderful. It gave us great closure. Secondly, regarding the All of Us research program, it is our second year that we just celebrated, and we did a series of Zoom celebrations, and one was a All of Us live. It was kind of like a town hall, and it went over so well that we have, emphatically agreed to continue that kind of a format. So to answer the question, what can we do to engage, with people during, these times of restrictions? We have definitely found that, either via chatting or video or Zoom, some sort of media like that to keep either a group of people or to keep a singular person involved, informed, really makes them feel a part of it, and it makes them feel included and informed. And so that is definitely something that we are doing here that, I'm sure others might or, could take from that.
Thank you. Thank you so much, Cheryl.
My pleasure. Mm-hmm.
So we know that we are after the 2 o'clock hour, and I see a hand up, Melissa.
Sorry, I do have one question that was not addressed, and it seems it's directed at Daryl's use of the term citizen scientist, and this is from Andrew Tarbox. He's an evaluation intern at Emory, and he's looking for some literature that discusses this term further. So
Term from Dr. Akintobi, because I was trying to figure out where I fit. I'm coming out of community organizing, but I'm also learning this science, and I'm evolving into an understanding of what I'm viewing that I believe to have been very scientific. And so Tab said, well, you're a citizen scientist. I said, is that what I am? And I enjoyed the description. It brought me closer to understanding my role in the work. So Tab, you got some
Yeah, well, it really is about community academic co-creation of approaches that mean something to communities. As researchers, even those of us who think we get it in communities, the places that we sit in are looking for research that is statistically significant. And certainly for communities who co-create and lead and guide us, like Daryl and many others, they help to check the relevance and accountabilities towards practical significance. That's what citizen scientists bring to the table. Certainly, I did not create the term. It is one that is broadly in the literature, and that we included explicitly in our work for the community engagement program for the Georgia CTSA this go round. So certainly with Katie and Lauren's support, we can send a couple of papers on the concept out to everyone. So I want to—
But you know, some of the outcomes of your work,
Mm-hmm.
I was about to say the outcomes of your work, guys, produce that kind of person in your community. Mm-hmm. There are people like me in all of your project communities who come from the same similar background that I've come from, who know communities, love communities, know organizing, and want to mobilize and empower communities. They just need a little bit more information about how to aggregate the data and the terminology and the acronyms of science to help them through. So look for those persons. They're in your communities. Link them up with your projects and watch the speed that happens, because they come with trust and they come with a lot of energy.
Thank you. And we, as academic scientists, do not know the science of communities. Only citizen scientists know that. And so that is where the synergy and the great kind of the sweet spot that moves things forward more quickly. So just so you know, we don't intend for this to be a one and done. You can go to georgiactsa.org to pull down information on what the Georgia CTSA does, but also the community resources connected to the community engagement program, whether you're trying to find a partner or you think you have one and want to make sure that you do it right towards community engaged research that matters. We're here to serve and support that. We have a 3-tiered opportunity for services, including sharing them with our board that Nisi is on, as well as Daryl and many others, as well as funding opportunities, capacity building workshops. And as she shared, March 31st to April 2nd, we will be having our annual biennial community engagement forum, but we certainly will share information through this listserv on other opportunities that present. We appreciate your time today. Community engagement matters to advancing a healthy Georgia, and we know that you all are all important parts of making that happen. So you can certainly reach out to me at takintobi, takintobi@msm.edu, or certainly through Lauren and Katie, or the link to the registration. You can get more information on the Georgia CTSA and the Community Engagement Program. Thanks to our speakers for making this so valuable and relevant. And thanks to all of you for your comments, questions, and the work that you do to advance healthier communities. Stay safe and let's stay connected. Thank you all so much. Take good care. Bye-bye.
Bye.
Thank you.
Thank you.